Hello, everyone. Thank you very much for joining us today. My name's Deborah Garlick from Henpicked, Menopause Friendly and Menstruation Friendly. And today at the Lunch and Learn, we've got a very fascinating subject: autism, ADHD, and the menopause. We're hearing so much about neurodivergence and how it affects somebody that's experiencing the menopause. We thought we'd just take half an hour and delve into one of our handpicked favourites, Dr. Clare Spencer, and say, what's actually going on here? How does this interact? What is the science behind this? I've also got my colleague Sally Leach, Director of Henpicked, here with me as well. So do feel free to let us understand any questions that you've got in the chat, and we'll try and answer as many of them as we possibly can. So, when we say autism, ADHD and the menopause, or for that matter, neurodiversity and the menopause, this is a relatively new area. And I know from a Hempicked point of view, the Menopause and Menstruation Friendly Employer Awards paid for a 3-year research program into menopause and ADHD, autism, neurodiversity to understand what was going on. Before that research, it was really hard to find anything that broached that subject. And I'm sure we've got a long way to go before we really understand all of the implications, but we can share with you what we know now. So, welcome, Claire.
Hi, it's great to be here talking with you again this lunchtime, Deborah. How are you?
I'm very well, thank you very much. And um, so I'm going to put it to you, Claire, straight like that. How is it that this is something that is quite emerging? Why didn't we know about this before? Because the stereotype of maybe ADHD is of a naughty boy running around a classroom and can't be controlled. But actually, what we're starting to hear is it's not just men, males, young boys that are affected by ADHD. Women are too.
No, absolutely. And it's totally the right question to ask. And I think the research that Henpicked helped fund that has really helped take a big step forward in this, because one of the major issues in this area is lack of research and emerging understanding of the challenges. So I think if we just take a step back and think about what do we mean by neurodiversity, neurodiversity is an umbrella term. It incorporates ADHD and autism, and these are heritable, brain-based, lifelong, and that's really important to recognize lifelong conditions, and there can be huge overlap between the two. And we know that women are often underdiagnosed, and particularly, I think what the research is showing us is older women. And I think there's a fact along the lines of, there are more older women who are not diagnosed with autism than younger women. And you're absolutely right that when we think about ADHD, so attention deficit hyperactivity disorder, our typical thought is that naughty boy bouncing around a classroom. But actually, you could have attention deficit as well as the impulsivity and the hyperactivity. And girls are slightly more likely to have the attention deficit type of ADHD, which means that they may just go under the radar through school. It's not recognized. And it's only now, I think it's brilliant that we're talking about it more and that we're having more events like this, that there is more research, that people are actually realizing, actually, maybe I have struggled with this for many years. Maybe this is me.
Wow. So it actually they weren't diagnosed, they didn't get diagnosis. And then it's when it comes to the menopause that that transition and maybe the fact that those masking skills
Hmm.
that girls can use when they're younger start to unravel a little bit. The lack of the challenges around change and communication actually amplifying what's going on during menopause.
No, absolutely. And we talk more about ADHD, but important to recognize that autism is part of that as well, particularly with communication. So, no, just to unpick that, Deborah, totally agree. So, what women will say to me is they've managed all of their adult life. They've got to university, they've managed their jobs, they've managed their family with the jobs, And then the perimenopause hits and the wheels come off. And that's what I hear a lot of. And similarly, women with autism, who again may have developed coping strategies, they've been able to keep a lid on that anxiety that might exist around, say, communication or other challenging features that they've learned to live with. And then suddenly the hormone change with the resulting structural and functional changes of the brain just mean that those coping strategies are blown out of the water and symptoms are amplified and far more challenging to deal with.
Wow, so there's a lot going on, but the thing that I find really interesting is there's a lot going on in your brain anyway during the menopause, isn't there? How do hormones affect our brain, our cognition?
Yes, and in many, many ways. So, as estrogen levels fluctuate and estrogen levels drop, there are structural and functional changes in our brain, neurochemical changes. So, the drop in estrogen results in a drop in dopamine. That might be implicated also in ADHD, in serotonin, which is that neurochemical that SSRI antidepressants increase, in GABA, which is a sort of inhibitory neurochemical that keeps a lid on anxiety, noradrenaline. So with the changes and the drop in estrogen, those neurochemicals levels change, so we can have heightened anxiety and a lower mood. And again, like neurodiversity, all the way through a spectrum of mild to severe symptoms. And I think what is pretty mind-blowing, pardon the pun, is our memory pathway literally changes sides from one side of our brain to the other with that change in estrogen. There are estrogen receptors in many, many parts of our brain. And so this is why when you lose estrogen, we have difficulty word finding, verbal memory, our working memory. That there are so many changes cognitively. The good news is most of them will improve with time as that adaptation occurs. But no wonder we are feeling sometimes like we're feeling
Well,
we go
quite.
through. And then add on to that the additional changes and challenges of living with neurodiversity. You can see how the symptoms are really amplified in the transition.
Well, you preempted my next question there because when you were saying about these changes in the brain, I was thinking,
Mm.
what for good? Is my brain never going to work again? Because we all recognize things like brain fog,
Mm.
high levels of anxiety, those
Mm.
sorts of things that are related or can be related to changes in our hormones. So, how do you pull apart then what's the menopause and what's ADHD or autism?
Yeah, that's a really good question. And that's when time and talking about symptoms and being listened to is important. So there are really strict diagnostic criteria for ADHD and autism. And when you look at the criteria, the stress is that these are lifelong conditions. So you don't just suddenly get symptoms out of the blue. With ADHD, for example, you have to have had symptoms from, I think it's below the age of 12. So it's where listening and looking back and thinking about also how you've managed other hormone change in your life as well. Because we know that women who are neurodiverse also may struggle with premenstrual syndrome, where we know there are those big changes of hormones in the menstrual cycle, may have struggled with postnatal depression, again, massive changes in hormones. And so these are all indicators. So it's lifelong symptoms, not just new in the menopause. And you may have also struggled previously with times of hormone change. That's a bit of an indicator that the perimenopause can be more challenging.
Absolutely. And one of the things when you're saying about if you like, how long somebody could be experiencing these symptoms, one of the things that would be my observation from years of supporting individuals and organizations is that many people don't realize when perimenopause starts. We all
Mm,
know the menopause definition, it's 12 months without a period. But actually, perimenopause is when this can all be triggered.
Absolutely. When that's because it's not just the drop in estrogen that can trigger symptoms for all women, it's the change in hormone levels as well. And we know that people with neurodiversity can be more sensitive to change in hormones as well as absolute levels. So that's a brilliant point to pick out. There are more pronounced changes in hormones at the start of the perimenopause and during the perimenopause. And it's the change in hormones, the more erratic fluctuation that can also mean that these symptoms just start to creep in early. It's not just waiting for a certain age, or it's not just waiting till your periods have stopped.
And you can understand, Claire, can't you, why some women say, I've had some women say, I feel like I'm losing my marbles because we've got a marker for menopause, but you don't necessarily know when the perimenopause is starting for you. You kind of might, if you've had the awareness and the education around menopause, identify some symptoms, but for some people, it might be more the cognitive ones. So, somebody's experiencing brain fog or higher anxiety
Mm,
years before the menopause, maybe even in the 30s, if they
mm.
start the transition earlier, or, because the average age is 45 to 55, but perimenopause could start in the 30s and you wouldn't necessarily associate it with menopause.
No, and that's right. And we have got periods as a bit of a barometer because to diagnose the perimenopause officially, you have to have had a change in periods or change in menstrual cycle. But if you're not bleeding because you're taking the mini pill, you've got a Mirena, other progesterone-only contraception, you really can't go by periods and you might just need to go by symptoms. And it's why, as we say all the time, Deborah, awareness, talking about symptoms, and if you are neurodiverse, understanding that what the symptoms can be and the impact that it can have on your pre-existing symptoms is so important.
Absolutely. Or as my lovely friend Sally would say, know your own body, know what's different for you, identify that, keep a diary. And but thinking about how you could support somebody that's experiencing difficult times during the menopause, or particularly when you think it might be neurodiversity and menopause intersecting, how
Mm.
does that look?
Yes, so this can look incredibly challenging, and this is why we need so much more research. So it's time, it's support, it's being listened to, it's being understood, it's recognizing the interplay and amplification, which I think is a great word in this context, of all of the symptoms, and also the impact that can then have on those around you, on how you interact with those around you, and how they interact back with you. And I think also it's really important to highlight the physical health changes as well, because obviously menopause is associated with increased risk of heart disease and osteoporosis. And often women and people who are neurodiverse have an increased risk of other health conditions also because of how they may interact or not or with health services and how health services may interact with them. So it's psychologically, it's cognitively, and it's physically, and it's thinking about long-term health conditions as well, and appreciating all of those domains and being able to get the appropriate help that you need, which is so easy to say, and I know so challenging to come by.
Do you know, Claire, it takes me right back to, we've done so much in the last decade to change understanding, change hearts and minds around the menopause, but we're
Mm,
still a long way from finishing. This is another area that just highlights, as you say, more research is required, but also we also not need to be talking about it and appreciating
mm.
that the individual nature of everyone's experience around menopause.
No, absolutely. And I know there are questions popping up about what can we do differently? What do we need to do? And I think that's absolutely it, Deborah. It's individualizing care. It's appreciating that it may take a number of iterations to find the right HRT for you. to find the doctor who can listen or other healthcare professional to find the support that is appropriate to you. Absolutely, it's individualized care all the way along.
Thank you very much. I'll invite my friend Sally to join us because I can see the chat going very, very busy in the background there, Sally.
Absolutely. There's so much, and I just, as always on these sessions, just want to say huge thank you for everyone sharing really openly, really honestly, and supporting each other, because that is why we have these sessions. Because when you know you're not on your own experiencing these things, it can make such a difference. So there's quite a lot of people sharing experiences, and I think one of the big things is about getting the right support. So just a few here that are kind of focusing around. I'd really like, so someone's got an ADHD combined diagnosis a few years ago, now waiting on autism. Life was always challenging, but definitely going through peri and experienced burnout during the pandemic. And with other big lifestyle changes, the wheels definitely fell off and my coping structures collapsed. Someone's asked, would really like help in how to get my GP to take me seriously with everything I say, as it just responded to it's either menopause or diabetes, and there's kind of dismissal of anything else. So, and there's quite a few people saying that they're confused about things, they're finding it hard to. How do you even begin discussing this with a doctor or therapist? As she's finding, someone saying they're finding life is really affected. So just really some advice, Claire, on that original, how do you start that conversation? How do you advocate for yourself with a healthcare practitioner?
Yes, okay. So let's start at the beginning. So number one, getting a diagnosis if you think that you may have autism or ADHD. And so there are often now mechanisms within GP practices where you may be able to bypass the GP. And if you tell the receptionist what you want, for example, in my practice, we can signpost you to somebody who can sit down with you and help fill in the forms for the to be referred off for diagnosis. So I think the first thing is seeking a diagnosis, because that can be then helpful and open doors in terms of it may be medication or more specialized psychological help. I think if it's the interplay of neurodiversity and menopause then and how to get listened to, it I think you just have to keep knocking at the door and keep trying different healthcare professionals or ask for a referral into a specialist service. It can be, so I know somebody said HRT is HRT the only answer, and no, HRT isn't the only answer. And HRT can be challenging in the menopause transition for people with neurodiversity, because often if you're neurodiverse, you may have slightly more extreme reactions to medication and changes to medication, changes to hormones. You may get more side effects. You may be more sensitive through no fault of your own, just through that hard wiring. And so it's not accepting that there's only one answer. It's going back, it's trying different hormones, it's getting that specialist help. And similarly with psychological help and support, it may be that what you need is slightly more specialized. And again, it's looking at resources. I know Henpicked have excellent resources, and again, trying to find. So I know when your brain feels cotton wool and it can feel like you're wading through concrete anyway, trying to put one foot in front of the other, but it really is just gently just keeping going back. It's not working. It's not right. Have the confidence to go back, have the faith in yourself to ask another question, to just see, because you can get there with HRT, you can get there with psychological help. You can get there with medication if appropriate, but it may just take a number of different tries and routes through. So hopefully that's a little way to help.
Yeah, absolutely. Someone's asked around a medication, citalopram. I always pronounce it.
Citalopram?
Yeah, is it an
Yeah.
SSRI antidepressant? They're going through ADHD diagnosis process, but it would be handy to know what it is they're taking and what that would mean if they had an ADHD diagnosis.
Yeah, so citalopram is one of many different types of commonly prescribed antidepressants, SSRIs, selective serotonin reuptake inhibitors, and they increase the serotonin in your brain, which can help decrease anxiety and help boost mood. Women with neurodiversity may not sometimes do so well with SSRIs. That is generalizing and it is individualized. It probably won't do anything to the diagnosis because to make a diagnosis of ADHD, again, it's looking back over a long period of time. But often just dealing with those symptoms can then heighten anxiety, which means that the anxiety needs managing. So it's one of the little cogs in everything, but it shouldn't make a big difference to the diagnosis. Hopefully that answers the question.
Yeah, brilliant. Thank you. Someone's asked around a confusion around, can ADHD be caused by trauma for some people?
Oh, that is a good question, and I don't 100% know the answer. There is a lot of ongoing research in this area, and I read something the other day about stress of the mother during pregnancy. Does that increase the risk of having a neurodivergent child? So I suspect it is one of the many factors, but really this is an area that is poorly understood with emerging data. The Royal College of Psychiatrists, their journal, often they're doing work around this area. But yeah, potentially, but I couldn't pinpoint you to
Yeah.
a
And I
to a
think
source.
it highlights that this whole area, say there is so much research that's needed, and it's why it's
Mm,
so important we're talking about it.
mm,
Um, So somebody has also put about the challenge of being diagnosed later in life as you're asked to get reflections from people in like
yeah.
past. And obviously for some people they may not have parents or they may have parents with living with dementia or things like that. And just that recognition of how do you go back historically? Again, any advice to try and do that reflection to try and separate out, is this a lifelong challenge or is it related to the hormonal changes of menopause?
Yeah, so I think that really highlights the need to go when you're looking for a diagnosis, go to an experienced, reputable clinician who is very experienced in this area because you won't be the only person with those challenges. And there are lots and lots of different clinics now that have set up to help with the diagnosis. And it's just really important to look for somebody with a lot of experience with the qualifications, and they will take it. It takes a long time to go through that consultation of being listened to and picking symptoms, and you really need to go to somebody who's experienced in
Yeah.
this area.
Fantastic. Deborah, this is probably one for you in terms of how do we approach this topic with our employer proactively? So if someone's struggling with this at work, kind of our top tips for how someone might get that help and support they might need at work.
Do you know, Sally and I was just thinking about the complexity of this because, as we were saying earlier, there isn't the years and years of experience and research on this. It really is emerging. So it's amazing to see so many people being able to share their story and ask questions about it because we do need to get that research done. And I do think there's an added complexity in the workplace because of the difficulty in getting a diagnosis. One of the things I was just thinking is actually, how do you ask for reasonable adjustments for something that you can't get a diagnosis for? And we've seen that, Sally, haven't we, with menopause, when people haven't had a diagnosis or their doctors said, I don't think it's the menopause, and the individual believes it is the menopause that they're experiencing that's resulting in symptoms and experiences that means that little bit of extra support at work while they're getting to the crux of what's going on is absolutely essential. But to do that, you've got to have an organisation that understands. And it's great to see that when you're looking at menopause action plans as part of the Employment Rights Act, that employers with over 250 staff will have to comply with, they do talk about intersectionality. And neurodiversity is a part of that intersectionality. But we've got to get to a point where we're raising awareness and understanding and education around something we haven't got all of the answers to. So, as Claire and I said earlier, everybody's experience is unique in this. And we say all the time during our training, Sally, understand yourself. I love it when you say that to people. Understand what's going on for you. Keep a record and actually then start a conversation with your manager around what it is that you're experiencing, what is it that you're doing, thinking maybe even outside the box. This is what would really help while I'm getting to the bottom of this situation, and then asking for reasonable adjustments and keep having those conversations throughout. So when that does mean that line managers have to be open for this conversation. They have to feel confident in having this conversation, which means that employers really do need to be not just having a policy and raising awareness, but also making sure their line managers are really confident in having these conversations and supporting.
Yeah, absolutely. And someone's asked, I'm keen to understand what as an organisation we can do. And I think one of the things, again, from the research that we've done with the University of Bournemouth that came through is if somebody's newly diagnosed with ADHD or autism, they may not at that point necessarily know what they need. Just being open to that conversation, and you say keeping that conversation going, I think that's so important because those needs may change over, or as somebody starts to come to terms with understanding themselves more, they may then feel more able to communicate what it is they need. But giving someone time and space, I think, is really important. So yeah, really good.
Yeah. May I add one thing on there? Because of course you don't have to have a diagnosis to ask for reasonable adjustments. You've
Yeah,
just got to have an organisation that cares for its people and will be supportive
yeah.
and will take this seriously. So I think that's an important aspect. And as Claire said, it takes a long time to get diagnosis. So start those conversations as soon as you identify that there's something going on for you that's making it difficult for you to be at your best at work.
Yeah, absolutely. Claire, we've got a question here around do autoimmune conditions such as thyroid issues affect ADHD and menopause or can have an impact?
So thyroid conditions can definitely have an impact on menopause symptoms, and the menopause can impact on thyroid function, and hormones can impact on thyroid function, and the amount of free active thyroid function, thyroid hormones. I don't know specifically. I'll have to come back to you if we leave that in the chat, and I'll
Yeah,
just go and do a bit of digging about the association of thyroid function and ADHD, and
yeah,
I'll be able to answer that. And I know somebody had mentioned, I'm really sorry if I've caused confusion about diagnosis and age cutoffs. There are different ways of diagnosing ADHD. It is quite complicated, and there are different criteria that people use. My talk was based on the DSM-5 criteria where there are ages, but you can be diagnosed later and it doesn't necessarily have to be from 12. And again, it's one of those areas where of grayness where that we do need more clarity, but it's not going to be the same for everybody. So apologies if I cause confusion, but yeah.
yeah. So I think someone's asked again around do neurodivergent people go through perimenopause a lot sooner than neurotypical? Is there any research on this? At the age of 35, I started getting symptoms, but when I speak to the GPs, I just get brushed off. I know we've talked about advocating for ourselves, but I think again, it's that, we know symptoms of perimenopause can start at
Mm.
very differing ages, but I don't, is
Mm.
there any specific research around it being earlier?
No, no, there isn't. And again, we do need more research. But what I would say is that it is totally normal, as Deborah said earlier, to start having symptoms of the menopause in your 30s. Although most women go through the menopause age 45 to 55. And if you think the perimenopause starts around 5 years before that, if you are going to an earlier menopause for whatever reason, you can start getting symptoms. But also it's important to know that in the later stages of your reproductive years before the perimenopause, premenstrual symptoms can be heightened. And if you are a woman with neurodiversity, then you may have worsening of your premenstrual symptoms anyway. And so it's just in picking what those symptoms are, what's the pattern, where do they lie within your cycle. But it's totally normal to have symptoms in your 30s. Again, it's just going back, take a diary of your symptoms, take a diary of your cycles. If you're not getting joy from the GP, asking for an onward referral would be my advice.
Absolutely.
I just want to come back to reasonable adjustments as
Yeah.
well, Sally, because I can see everybody giving everybody this is, the advice around this. And this to me is just like the menopause. It's really hard for some people to get diagnosis. And I know some people are saying, oh, well, we can't get reasonable adjustments without a diagnosis for menopause or whatever it is. But I would come back to the actually, you can. And
Mm.
this is about a really good conversation and working for an organization that understands that sometimes we need a little bit of extra support, whether it's neurodiversity or whether it's menopause. So you can ask for them.
Mm.
Absolutely. And I'm just putting in the chat again. We will share a recording because I know there's so much we've covered here. We'll be sharing the recording. We'll also write up an article so that people can have all of the content we covered. But just want to say huge thank you. People have been so honest, sharing and supportive. Many people are finding HRT has been life-saving for others. Lots of things around nutrition and lifestyle. Um, the research, just one quick question. The research from the University of Bournemouth, Deborah, do we know when that's published? When
Um,
that will be published?
it takes a while. It's all written up. I would probably, and I'll add this to the article when we write it up, so you can find it on the Henpicked website. They have written a book about their experience, but I think it'll be another year to 18 months before it's all published. The good news is, my understanding, Claire, is we're not waiting for that piece of research. There's already other pieces of research that people are starting to look at. You mentioned a couple of them earlier, and I say, this is absolutely what we need because it's great to see what's happened with menopause, but actually that appreciation around intersectionality and all our experiences are different is essential to make sure that people understand that. It's not a sheep debt, it's an individual experience. So thank you very much, Dr. Clare, and thank you very much, Sally, and thank you very much for joining us. I think we need to cover this again at some point. But we hope you enjoyed that session. And as Dr. Clare said, there are more resources available on the Henpicked website, and we will be finding out what's happening with the research so we can update you on that too. So thank you very much, everyone.
Thank you.
Bye, bye everybody.